321 is talking about the rheumatic fever. It's basically a consequence of the pharyngeal infection with group A beta hemolytic streptococci. So that's the culprit, that's the main causative organism. It's group A beta hemolytic streptococci, and it happens in the pharynx first. So the late sequelae of that include rheumatic heart disease. So the rheumatic heart disease, it affects the heart valves, so more in the mitral than in the aortic, which is also happens more in the aortic, more than the tricuspid. So it depends on how much the pressure within that valve is. So its high pressure valves are affected most. Early valvular regurgitations, that what we see at the early stages of the disease, valvular regurgitations, but late we can see valvular stenosis developing as well. So it's associated with, well, this is what makes it so different. Ashoff bodies, they are granuloma with giant cells. These are the blue arrows in A. So this whole thing, which is purple. So this whole thing is the Ashoff body. It's basically a granuloma with giant cells. There's specific cell within. That is the anti-show cells. They're enlarged macrophages with ovoid, wavy, rod-like nucleus. So enlarged. Is the red arrow. So this is the red arrow. Okay. So it's enlarged, um ovoid, yeah, and wavy. Well, makes sense. It doesn't go like straight or something. Okay, wavy rod-like nucleus. Okay. That's the anti-show cells. They are found within, actually, the collection of anti-show cells next to another anti-show cells and everything. That what makes the Ashoff bodies in the first place. So they are, the collection of those, the accumulation of those will lead to the Ashoff body. We also can find in the rheumatic fever, we can find an increase in the antistreptolysin O. It's a toxin that causes somehow lysis of the RBCs and other stuff. It attaches to the cholesterol, as much as I remember. And there is an increase in the anti-DNase B titers. Okay, so there is increase in the antistreptolysin O, ASO, and then also there is an increase in the anti-DNase uh, B titers. So it's this disease, the rheumatic fever, is actually immune mediated. So it's not the direct effect of bacteria. So it's not that the bacteria itself is causing the problem. With what's causing the problem is how the body reacts to that bacteria. So it's immune mediated. And this kind of reaction is considered type 2 hypersensitivity. Um, because now we have antibodies to the M protein, that is found, of course, in the heart as well. These antibodies that the body produce against the bacteria, they will attack the M proteins and they cross react with the self antigens. So the self antigens is just the normal parts of the body that should not mm, uh, be involved in the immune system response, but somehow they get involved. So often these M proteins, the ones that they get affected in the rheumatic fever, are the myosin. It's the myosin, and the whole process of the immunity attacking the myosin or the M proteins, because of the type 2 hypersensitivity, is called molecular mimicry, because these molecules look similar to each other, so it's hard for the immune system to actually differentiate what to attack from what to not attack. So, the treatment is the same as the prophylaxis to prevent the whole thing, and that is penicillin. So, we need to use penicillin. The major criteria are joint, well, Jones, The O is kind of hard. So the J stands out for joints. That is migratory polyarthritis. The important stuff is migratory. So one day is in the foot, the other day is in the hand, the other day at the finger. So it just different from it goes on from one place to another. That's migratory polyarthritis, and it's not only affecting one place, it's poly, so it's more than one site. And also we can have carditis, of course, because it's a rheumatic fever. This is what we're talking about. We can find nodules in the skin as well, and they are subcutaneous, so they're not on the outer surface of the skin, they're just subcutaneous. We also can have erythema marginatum. It's evascent rash with ring margins, so this rash kind of vanishes every once in a while, but if it comes up, then it shows with a ring margin. That's the erythema marginatum. And also we can have pseudonym chorea, and that is involuntary irregular. So it's involuntary and irregular movements of the limb and face, and that is due to the immune complex deposition in the brain, specifically in the basal ganglia. So that should be it for the rheumatic fever. Now for the syphilitic heart disease. So we have, if we have tertiary syphilis, that will disrupt the vasa vasorum of the aorta. So basically, the vasa vasorum are the teeny tiny arterioles or arteries that actually supply the aorta. I mean, the aorta. So if this was the aorta, so its walls needs some blood to supply it, and the vessels that are supplying the walls of the aorta are called vasa vasorum. So unfortunately, the tertiary syphilis affects these really small, teeny tiny blood vessels over here that are around the aorta. So and it may cause them to have endarteritis. So they just obliterate somehow. So because they obliterate, they cannot provide enough blood to the wall of the aorta. So this is the aorta. So they cannot provide enough blood supply to the wall of the aorta, and that of course makes the wall of the aorta weak, and if it goes weak, then the problems start to happen. So it says that the tertiary syphilis disrupts the vasa vasorum of the aorta, with consequent atrophy of the vessel wall and dilatation of the aorta and valve ring. So atrophy of the vessel wall, okay, dilatation of the aorta, and valve ring. We may see calcification of the aortic root, okay, calcification of the aortic root, and then ascending aortic arch. Well, wow, the calcification could be seen in the aortic root, in the ascending aortic arch, and in the thoracic aorta. So three main places where we can see the calcification: the aortic root, ascending aortic arch, and thoracic aorta. That leads to the tree bark appearance of the aorta. And if we take a look at this image, so this is the tree bark. This is how the tree bark looks like, and this is the intima of the ascending aorta. So it's they kind of look really similar to each other. So that's why it's called the tree bark appearance of the aorta. It can result in aneurysm because, of course, the wall of the aorta is now weak because the vasa vasorum are obliterated or diseased, so they don't supply as much blood as it's needed. So that's how we have aneurysm of the ascending aorta or aortic arch, and of course also aortic insufficiency. And that's it.